When life gets unpredictable, preparation matters. In medicine, it's all about staying alert, ready for whatever comes through the door. On the road, it's no different. That's why Volvo designs vehicles to help anticipate risk, reduce harm, and protect lives. The Volvo XC90's advanced safety systems inspire confident decisions wherever the road takes you. The Volvo XC90, for life. Proud sponsor of the Pit Podcast. Learn more at volvocars.ca/safety.
On a need-to-know basis, he's got you covered. Elias Mackers, CJAD 800.
Welcome back. David Heurtel in for Elias. Well, been talking about the situation in our emergency rooms. The COVID numbers, the RSV numbers are up. Deaths are up. And think about it. We have started to see emergency room numbers the way we did a year ago when we were tracking these on a daily basis. The number seems to be coming back. So as we're facing this impending crisis in our emergency rooms yet again, there's the question about vaccinations because the numbers are incredibly down. We have collectively seemingly stopped getting vaccinated. The drop for the third and fourth shot, and let's not talk about the fifth shot, it's drastically low compared to the first and second one. So to talk more about this, always a pleasure to speak with Dr. Christopher Labos, cardiologist with a degree in epidemiology, who can be heard at 8:10 on Sunday mornings on CJD 800 on Weekends with Ken. Dr. Labos, always great to talk to you.
Yeah, good to talk to you too.
So tell me about this situation. I mean, what's the vaccinated situation right now in Quebec?
It's not great, to be honest with you. While a lot of people, got their first two doses, very few people have been keeping up with their booster shots. And there's a fairly large segment of the population. I haven't looked at the most recent numbers, but a lot of people have not gotten boosters, and a lot of people are more than 6 months out from their last dose. And for a lot of people, their last dose was not the bivalent, right? It was, the older generation original ones. Now, individually, none of those things would necessarily be a problem. But you have all of those things happening together with rising COVID numbers, with the suggestion of more infectious variants, and with the emergency rooms being what they are, being overwhelmed with not just COVID, but also RSV and the flu. There's a lot of elements coming together in a very, very suboptimal fashion. When people talk about a perfect storm, it's this. It's where you have a bunch of things happening simultaneously, and maybe each one of those individually would be manageable. But it's very hard to cope when you have all of this stuff happening simultaneously because there's only so much redundancy that can be built into the healthcare system.
I remember us talking, a year ago, literally. A year ago, I was on CJD. I was hosting Montreal Now. You were on the phone with me, and we were talking about these vaccines and people getting vaccinated and the first dose and the second dose. People were following it. The numbers were very high. Yeah. What happened? I know I'm asking you a tough question, but why? I have my 4 shots, and I'm following the 6-month directive, to follow this. And then my next shot, I think, is going to be in February. But why aren't Quebecers keeping up? And it's not just Quebecers. Let's face it. This is all over North America. But why aren't we keeping up?
I think partly it's a question of the messaging and the tone of the messaging. You had several months, frankly, of the government and public health telling people things are fine. We don't need to do anything. So when you tell people things are fine, they interpret that to mean steady as she goes. There are people, I have people coming into the office, genuinely confused. They're like, why do you still care about COVID? And I'm like, why do you still care about COVID? I think a lot of people just have no conception of what's actually happening in the healthcare field now. I was speaking to somebody the other day. The other thing, too, is that a lot of people, if you remember the messaging really at the beginning of the vaccine rollout, a lot of it was, go get your 2 doses, and that's what's going to let us get back to normal. And a lot of people took that as a verbal contract. They said, I got 2 doses, now I'm going to do whatever I want. And I had somebody literally say to me, I got 2 doses, and I am not going to get any more unless the government forces me. Which was a weird thing to say if you think about it, because they're not opposed to getting more vaccines, but they won't do it voluntarily, which is an odd reflection of human nature if you think about it. So
totally.
Yeah, but that's it. I think a lot of people bought into the original messaging. I need 2 doses. I got 2 doses. I'm done. I'm not at high risk. A lot of people also bought into the things like I'm young and healthy. I don't need it. So I'm checking out of this conversation. And I think a lot of people have checked out of the conversation because they don't see it as something that directly affects them anymore. Because the reality is that, you know, if you're young and healthy and don't have pre-existing medical problems, you probably won't end up in the emergency room. You probably won't end up in hospital. And so what's happening there is something that is to a certain degree out of sight and out of mind.
I have a texter writing, hi, David, can you please ask the doctor if the booster currently being dispensed is formulated for the current variants?
So the ones that we have now are the bivalents. They were initially designed against BA.5. BA.5 is admittedly making up a lesser proportion of new cases. We're seeing much more resurgence of BQ 1.1 and some of the other variants. The feeling is that all of the Omicron subvariants are similar enough that if you have antibodies against BA.5, they are likely going to give you good enough protection against the new one. So, I mean, ideally, we would want to have the vaccines updated to better reflect the circulating strains. And my hope is that, you know, as we go into the coming years, we're probably going to start looking at the COVID vaccine as we look at the flu vaccine, where we basically formulated a few months in advance in anticipation of what we think the fall and winter months are going to look like. We just haven't really fallen into that seasonal pattern quite yet because COVID has been, as the saying goes, predictably unpredictable.
Can I ask you about everything we've been hearing with the emergency rooms and the crisis? You're on the ground from your perspective, because for someone like me who's been following this, of course, very closely, but I'm not a healthcare professional. I'm not on the front lines, but it seems that every year we're asking the impossible of our healthcare system. And somehow the healthcare system seems to be being able to deliver, but there are consequences to being able to deliver crisis after crisis. I mean, how are you seeing the next few weeks in our emergency rooms and the healthcare system in general?
So short term, people will cope because that's what people do. Everybody sort of digs deep and says, okay, we'll make it happen. We'll double up the patients. We put patients in hall rooms. We have, even at the best of times, work above capacity, and the people who do frontline care, especially people who work in the emergency room, are used to this sort of thing. It's the long term that has me worried because at a certain point, people burn out, and that's what you're seeing. You're seeing more and more burnout. A lot of people walking away. It is bizarre to me that it has become a normal conversation starter to go to my colleagues and people being like, hey, are you thinking of going private? I mean, the conversation about privatizing the healthcare system has taken off in a way that would have been conceivable even 5 years ago. So most people think it's like, oh, you go private because you want more money. No, people go private. They leave the hospital system. They leave the public healthcare system because they find it too difficult to work in there. You probably are not going to make any more money in the private system. Maybe you'll make a little bit more. But most people who do it, especially when you're talking about nurses who leave the hospital system, it's the working conditions that just get to them. And if we don't find a way to improve the working conditions to retain staff, especially nurses, but all the allied healthcare professionals that work in the hospital, it's going to become increasingly more difficult to do things properly. And you're going to have more and more people saying, I'm done, and walking away from the system. And that's going to start the downward process that, might end up leading us into like a parallel healthcare system. I mean, it's not inconceivable now to look forward and think like, we're going to have, we already have a fair degree of private medicine already in this province. It could get substantially more prominent as we go.
Are you or the people around you seeing a solution, for example, on the forced overtime situation or in the ERs, a solution, a partial one that is being discussed but not being put in place?
I mean, I think there's a lot of ways that you could deal with. Number one, and sort of the most fundamental, is that if you want to decrease overloaded emergency rooms, you just need less people showing up to the emergency room. So, I mean, you can either mop up the water that's being spilled out of your sink or you can turn off the tap. So we're not very good at turning off the tap. And so preventing illness is the first one. So that's why you will often hear people like me and the many other physicians who do public science communication to talk about the importance of masks, of getting your boosters, of staying home if you get sick so you don't start spreading illnesses during the Christmas get-together that you plan. So one thing is to just prevent people from getting to the emergency room. But the other thing is we need to find an alternative venue for people to then going to the ER. Some people go to the ER because it's an emergency and there's just no way to get around that. Mm-hmm. But a lot of people go to the ER because they're sick, but they have nowhere else to go. And so if you wake up and you have a very bad cough and fever and you're short of breath, and you don't have access to a family doctor, well, I mean, what are you going to do? So if we want to decompress the emergency rooms, we're going to need more walk-in clinics, more urgent care clinics, things where you can go when you are acutely sick, but where it's not necessarily an emergency that requires hospitalization. And so you started to see some of that. The government, opened up these 2 nurse practitioner-led clinics, so that will help a little bit. And if we can do more of those things, that will help at least in the short term. And long term, we just need more family doctors. We need to attract more people into family medicine and give them the resources to do the things that they need to do, because family medicine is not just about medical care. It's also about, nutrition and physiotherapy. You need all these allied healthcare professionals that are right now not necessarily covered as part of outpatient medicine. So it's very hard for a family doctor to do what they need to do when they don't have the resources to diagnose you. If you go up to your family doctor with a cough, well, I mean, they need to swab you for influenza, for COVID. They need to do a chest x-ray to make sure you don't have bronchitis or pneumonia. I mean, so if they don't have the resources to do that on site, well, they have to send you somewhere else, and that just creates delays and frustrations in the system.
Very interesting, as always. Thank you so much, Dr. Labos.
My pleasure. You take care.
You too. Dr. Christopher Labos, cardiologist with a degree in epidemiology, who can be heard at 8:10 on Sunday mornings on CJAD 800.